Hey everyone, I hope you're all doing super well. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about peripheral vascular disease. So, what is peripheral vascular disease? I think one thing you need to really establish from the get-go is the fact that it is a macrovascular arterial disease, primarily due to atherosclerosis. Why is this important? Well, we talk about microvascular diseases quite extensively with whether it be diabetes, whether it's nephropathy, neuropathy, retinopathy. But you need to know that PVD itself is a macrovascular disease, which means it broadly affects bigger vessels. In terms of its prevalence, it is quite common, especially in older demographics, with a peak incidence of about 60 to 80 years. So I think it's really important to understand what's going on here at an arterial level. So remember, I said that this is a macrovascular complication. It means it's affecting the larger arteries primarily. In saying this, it can also affect smaller arteries, but those would be microscopic, obviously. And the main symptomology that we think of when we think of PVD relate back to those big arteries. So what is happening in those arteries, firstly? Over time, with high levels of blood cholesterols and LDLs, we have slight depositions of them into the arteries, right? Into the tunica intima of the arteries. Over time, this leads to irregularities in the inner surface of the arteries, which causes turbulent blood flow. The more turbulent the blood flow is, the more likely the tunica intima is going to be damaged further. This leads to a whole bunch of inflammatory cells being released, which then absorb these LDLs to form something called foam cells. These foam cells then also deposit with those LDLs into your arteries. As you can imagine, this is not good and leads to the development of the first kind of stepping stone to PVD, which are going to be your fatty streaks, which start to develop even in one's early 20s, which is not great news. Over time, as you can imagine, this degree of deposition increases and the artery lumen narrows, creating kind of a stenotic picture. And this stenosis is what leads to the symptoms and complications of PVD. As you can imagine, with any kind of tubing system, blockage anywhere is almost always going to affect the distal parts first and then the proximal parts, right? Which is why when we think of PVD, most of the symptoms we see are going to be primarily at the feet moving upwards. So let's look at the arterial supply a bit closer. But before we do that, again, as I mentioned, PVD is macrovascular. In saying that, you can have patients with PVD having microvascular damage, but that is often going to be due to something else, something like diabetes, which you know causes both macrovascular and microvascular complications. You also need to know that the stenosis we see in PVD is only because of atherosclerosis. In saying that, you can have a kind of hypoperfusion and compromised blood flow due to other factors like an inherent inflammatory picture like a vasculitis, but that is not going to be your stock standard PVD. And we'll talk a bit about the various differentials for PVD in a second. I think it's good to have a good understanding of the arterial blood supply. And a common question that I also found myself asking was, well, why is it affecting the arteries and not the veins? And there are two main reasons for that. Firstly, in terms of pressure and in terms of blood supply. So the actual supply obviously is going to be arterial in nature, and therefore compromising the upstream, which is going to be your arteries, would lead to hypoperfusion, right? Where your muscles will not get enough oxygen. However, if you kind of flip the picture, if you were to damage your veins, it could lead to a chronic venous insufficiency, but would not cause your typical hypoperfusion picture. Secondly, and more importantly, because your arteries are more so stiff than your veins and less compliant than your veins, they are more likely to undergo atherosclerotic damage, right? In saying that, you can still have damage happening, the same thing happening in your veins, but because they are so compliant, it is unlikely that they're going to cause a similar degree of stenosis. So looking at our arteries, we have our external iliac leading into the femoral. This would lead into the popliteal, the tibial, and then the dorsalis pedis, as well as the plantar arch. Now, this is important from an examination perspective, because when we examine the lower limb as part of our PVD as well as a diabetes exam, one of the key things we look for are going to be our pulses. And therefore, we start off by assessing the distal pulses first, moving proximally. And that's really important. So let's talk a bit about how does this present. I think instead of trying to memorize a list of signs and symptoms, let's think about what's happening here in terms of the disease and how that correlates to symptoms. So first and foremost, we have stenosis, right? We already talked about that. This is going to lead to hypoperfusion. Now, this hypoperfusion is going to be relative to two things. Firstly, the blood supply, how stenotic the actual arteries are, where the actual blockage is, because as you can imagine, this blockage can be anywhere along this entire system. Yes, it is more likely to happen peripherally first, but you can have blockages or stenosis anywhere. Secondly, what is the actual demand of the muscle, right? Because your muscle at rest is going to have a very different oxygen demand than if you are undergoing vigorous activity. So having a good idea for when you are hyperperfused is good to assess the severity of PVD. Apart from that, in terms of a practical approach, we need to, I guess, assess their severity to kind of figure out how aggressively are we going to treat them. And it's really good to understand what their general level of functioning is. So a really good way I've found to ask that, or ask just general functioning when it comes to patients in their cardiovascular health, is assessing their exercise tolerance. So I know historically we've been asked to ask things on a scale of 1 to 10, but more pragmatically, I think it's useful to ask how far can you walk before your symptoms kick in? And as you know, the most common symptom they're going to have is intermittent claudication, or the pain after prolonged or after exercise. So how long do you usually walk for before this pain kicks in? How severe is the pain? Is it just one muscle group, or are there a few muscle groups that are being affected? How long does it take for the pain to get better after you stop exercising? Do you have pain at rest? Because that obviously would indicate kind of a more moderate to severe picture. And does it get better with elevation? Because PVD pain, as you can imagine, would get better with elevation. So let's move on to our history taking. And whenever you take a history and you may suspect a compromised arterial supply, always assess your 6 Ps of acute limb ischemia. Acute limb ischemia is not really a subtype of PVD, but more so a complication where they may have possibly an occluded artery that's going to cause limb ischemia and then eventually necrosis and gangrene. So the 6 Ps are pain, pallor, paresthesia, which is reduced sensation. Pulses would be diminished, they would be perishingly cold, and also paralysis. It's important to know that the last two, the temperature and the paralysis, they're quite specific to peripheral vascular disease. So as we talked about, the most common presentation being intermittent claudication, as with any history, you would go and you would assess your WWQQA, you would quantify the pain as well as our exercise tolerance. But it's also good to ask which muscles are being affected, as I mentioned earlier. Is it their calves? Is it their thighs? Is it their buttocks? Because that can give us a good idea of where the primary stenosis is. For example, if you have a stenosis at the level of the popliteal, you're going to have pain in the muscle groups below this. I think that makes sense, because obviously, if the blockage is here, anything beyond this is going to be affected, right? You're not really going to have pain in your gluteal region or your quads because the blood supply to those regions is still intact. So that's a really good tip. It's also good to ask if they have any other symptoms of macrovascular damage, because as you can imagine, all of these go hand in hand. So asking if they have any chest pain, whether they've had any neurological symptoms, or if they have a history of strokes or AMIs. It's really good to also ask about their exercise history, whether they consume alcohol and or if they smoke, as these are going to be things you want to target as your risk factor minimization in your management strategy. Lastly, if you suspect that this may be an inflammatory vasculitis, like Takayasu's arthritis or thromboangiitis obliterans, it's also good to ask about systemic signs and symptoms. Like, do they have a fever? Do they have general tiredness, lethargy? Do they have Raynaud's phenomenon? We also have a specific kind of pain. It's called migratory thrombophlebitis, and that's quite typically seen with Berger syndrome or thrombolaryngitis obliterans, and we'll talk about that in a second. But with those kind of symptoms, it almost doesn't make sense. It's a younger patient. It's not your typical stock standard patient, although it is unlikely that this would be assessed as part of an examination matrix. When you examine these patients, this may be often quite tricky because we're not really taught a peripheral vascular examination per se. But if you know your diabetes exam, it's quite similar because obviously one of the key components of a diabetic exam is assessing macrovascular damage. So you'd be looking for, obviously starting with general inspection, any muscle wasting because you would have hypoperfusion, signs of a DVT, which obviously patients with PVD are at a high risk of because of the procoagulatory state. Do they have varicose veins, which may indicate chronic venous insufficiency? Do they have any ulcers? And it's important to know that ulcers can be arterial, venous, neuropathic, and we'll go through that as well. Hair loss is a good one because hair loss is quite commonly seen in diabetic patients. Now, the etiology of hair loss, especially on the lower limbs, is mixed, but it's predominantly microvascular. So if you see someone with almost no hair on their legs, you may ask yourself, do they have something else that's predisposing them to having a compromised microvascular arterial blood supply? And that's when you think down the diabetes pathway. And then there's also this condition called necrobiasis lipoidica, and it's basically an irregular discoloration of the skin, again, quite commonly seen in diabetics. And that's just described here. Then moving on to feel, you want to assess their capillary refill, often done at the big toe. You want to assess their temperature. Are they cold? Are they warmer than usual? Assessing for color as well. Are the feet particularly pale or hyperemic or red? And then moving on to pulses. And pulses are probably the most important thing you're going to look for in this examination. So you always start distally and move proximally, starting off with the dorsalis pedis, which is between the first and the second metatarsal, then the posterior tibial behind the medial malleolus, the popliteal, and eventually the femoral. So that's the dorsalis pedis, the posterior tibial, and the popliteal. A common question is, do I need to do all the pulses, or is one just enough? Usually, if you have a good dorsalis pedis pulse, it would almost indicate that you definitely have normal posterior tibial as well as popliteal and femoral flow, because it's quite impossible to have one without the other. But obviously the inverse is not true, right? So if you have a good femoral flow, you can still have a compromised dorsalis pedis. So for a PVD perspective, it should be sufficient, but then know that we're obviously checking for a few other things. We're checking for popliteal aneurysms, which can present in a similar kind of arterial insufficiency picture. So that's good to look for. And just for being thorough, I would still recommend going through all four. A special test for PVD is a test called Berger's test, where we kind of dangle the patient's leg by the side of the bed. We firstly raise it to 45 degrees, and rapid loss of color or rapid pallor is a positive sign because it indicates that the blood flow is not sufficient, especially when you're elevated. So that's the first positive sign you look for. And secondly, you elevate the leg below the level of the bed and then check for a rapid change in color or redness or hyperemia, meaning that you have almost too much blood flow. And again, it's kind of a slushy system where you don't really have a normal, consistent flow. And that's, again, a positive test. So the two combined can give us a good estimation. The second and the diagnostic test for PVD is called the ankle brachial pressure index. So for this test, we basically attach 4 cuffs, 2 on the arms and 2 on the 2 at the ankles, and basically assess the systolic ankle pressure divided by the systolic brachial pressure. In a normal person, this should be the same. However, if you have a compromised vascular supply to the ankles, which is what's going to be most commonly affected with PVD, you're going to have a reduced ankle pressure, but still a relatively intact brachial pressure because it's very close to the aorta. So although you still may have macrovascular damage in the arteries, which would be assessed by the brachial pressure, it's not going to be as severe as the ankles. It's also important to know that a relatively high ankle brachial index can indicate arteriolosclerosis, meaning that the walls of the arteries are so stiff that the pressure in the ankles is actually much higher than that of the than that at the brachial level, and that's abnormal as well. But for PVD specifically, we look for a reduced ABPI. Anything below 0.9 is usually considered confirmatory. Anything less than 0.5 is considered to be severe with imminent limb ischemia. Other differentials to consider, which I briefly mentioned, the two vasculitides, which are inflammatory, are Takayasu's and thromboangiitis obliterans, or Berger's syndrome. We're moving on from eponymous names, which is why we're using longer, more complicated words, but they practically, you might have heard of Berger's disease or Berger's syndrome. So Takayasu is a middle to large vessel arteritis, commonly seen in young to middle-aged Asian women. So in addition to the PVD picture, they will have systemic signs: so fever, arthralgia, syncope, angina, and even changes to their vision sometimes. With Berger's disease, it's more common in males and is has a very high association with smoking. The exact etiology, I'm not quite sure as to why that is the case, but again, it's partly due to that inflammatory and atherosclerotic picture. It's characterized by migratory thrombophlebitis. Now that's a bit of a tongue twister for me, but thrombophlebitis is basically inflammation and redness that is migratory. So it's not in one place and can often change, as well as Raynaud's syndrome. Now, you may have heard of Raynaud's, and Raynaud's commonly comes up in Raynaud's phenomenon and Raynaud's syndrome. The difference between the two being Raynaud's phenomenon can often be of no particular concern or significance. Many people can have Raynaud's, especially with cold temperatures, but Raynaud's syndrome itself is pointing towards a pathological cause, in this case, Berger's disease. And the most important thing you can do for them is focus on smoking cessation. You also have fibromuscular dysplasia, which affects the proximal muscles and vessels before the distal terminal ones. You can have popliteal aneurysms. As you can imagine, if you have the popliteal artery that's ballooned up or has had an aneurysm, you're going to have compromised distal blood flow. And the other big one would be diabetic neuropathy, because that too can present with ulcers and microvascular arterial complications. So how do we manage PVD? The first thing, as always, is going to be lifestyle changes. So diet, exercise, smoking cessation, screening for other cardiovascular and metabolic syndromes and controlling them. And then in addition to that, it's you are going to want to start them on some medications. And what we think of are kind of our stock standard cardiovascular therapy for metabolic syndrome. So we're going to start them on a statin, an ACE inhibitor, an antiplatelet therapy, probably clopidogrel. The evidence for aspirin is equivocal for this particular case. The reason we start them on an antiplatelet is because they are at a higher risk for clots, not just peripheral arterial clots, but also AMIs and strokes. And then obviously assessing their HbA1c and the need for diabetic therapy is also important. Once they go on and have moderate PVD, which based on our ankle brachial pressure index would be between 0.5 and 0.9, we might consider something called cilostazol, which is a phosphodiesterase inhibitor. And it basically works by acting on the CAMP pathway to help almost minimize or reverse that atherosclerotic plaque buildup. Once you've progressed onto severe PVD or had an episode of acute limb ischemia, medical therapy is probably not going to do the job. So you move on to more surgical means. And the three main ones in order of severity are percutaneous transluminal angioplasty, a big word for basically putting in a catheter and a flexible balloon to open up whatever has been damaged or stenosed. We can also do an arterial bypass, where if we can identify the blockage, we might use a venous graft to bypass that. And lastly, if nothing else works, or if they have a necrotic limb or gangrene, we might consider an amputation. And that's obviously going to be reserved for kind of last case situations. And that's all we had for PVD today. If you have any questions, please feel free to contact me either through email or on Facebook, and I'll be sure to get back to you. And yep, as always, please look after yourself and look after your loved ones, and I'll see you guys in the next one.